Good evening, everyone. So thank you for coming. Thank you for making the trip over here. My name is Jacob Cresswell. I lead the TB Reach initiative at Stop TB. Tonight, we're going to talk about the new funding wave that we're launching today. So now I'm going to pass the floor to a person who needs absolutely no introduction, but our executive director, Lucica Diciu, and have her say some words of welcome. So thanks.
Thank you, Jacob. And I want to start by, first of all, thanking all of you for being here in such a large number. It's amazing, and it gives a sense not only of partnership, but of hope, right? Because we are together up to our neck in this bloody disease, but we will manage to make a big dent in it. I have zero doubts. So, as Jacob said, I hope everybody knows what is TB Reach here, but actually after I said, I will see who doesn't know, actually it would be good if we have people that don't know what is TB Reach, because we need people from outside our own community to come more on board. And the new call for proposal that it will be launched tonight, it will be a lot about that. So TB Reach, it's, Jacob is right, myself and Sahu actually, with a lot of input and love from the Canadian government, created TB Reach. And for me, it's a structure that must continue, and because it's our only structure in TB and in global health that takes risk implementing things that are not yet fully proven. There is nothing like that. Everybody takes a lot of measures before they put money into something. We should be allowed to make mistakes. We should be allowed to try some things if we think strongly that they fit very well to what we have in our own community and so on. And the guy that, when TB Reach was created, there was 120 million Canadian dollars that were given to stop TB. And there was a gentleman called Ernest Levinson, who was the brain behind it. And we had several calls with him. And we insisted, and he was so happy. And I was very happy because he was the only at that time, the only donor that with whom I stayed and debated this, and who said, yes, okay, you know what, you're right. Because what we were trying to say was solutions that are pushed from Geneva or London or New York or Washington or whatever are not working in the countries. And solutions that work in Rwanda will not work in Kazakhstan, and solutions that work in Romania will not work in Kenya, and so on. And that's why people that are in those communities will know much better how to find the people, how to treat them, how to get the hook. And this is what the energy of TB Reach came. And for me, I think Canada was amazing because we said, but there will be mistakes. There will be things that will not work. That's fine. And actually, myself, Jacob, and Sahu, we have a dream. We have a dream that we have a conference that is devoted to the failures we had, the things that didn't work. Let's speak about the things that didn't work. Stefan is here. Many years ago, you remember when we were going to screen people in two Romanian counties because they were from a vulnerable group. And I was very convinced that we will find a lot of TB there. And we didn't. We spent a lot of money and we found 2 or 3 people because a lot of assumptions were wrong. But we need to learn from mistakes, and we should be allowed to make mistakes. And at a certain point, there should be donors allowing to, taking some risks that if things don't turn out well, at least we don't go there. It doesn't work. And this is what TB Reach does. It's not just about taking the risk. It's trying to find all these amazing innovations, and it grew up incredible well. And Jacob and the team, and Amera and Bea and Pauline and Tofik and the colleagues here, and Jürgen, and doing a fantastic job there. We started the first round. We had this incredible application of Lesotho about buying donkeys and horses that I keep speaking about. And I speak about this because Sahu knows. It was me, Sahu, and the guy, Edin Karahasanovic, who was our assistant. And we had to go to WHO, which is anyway having sometimes challenges in moving things around because it's a very solid institution. So we had to go to get approval to buy 200 donkeys in Lesotho. And we managed to do that, and we bought, and then Global Fund contributed, and now Lesotho is doing their own stuff. And that came because the Minister of Health of Lesotho, she said, Luchika, she was in our board, if you remember, those of you old, like some of us. She said, everyone in Lesotho is building us laboratories. My people don't reach the lab. Their sputum don't reach the lab. So I need vehicles. So can you buy these horses? So that's how that proposal came. Then we had drones in Madagascar, which is like the other thing, which was a fantastic project. Was what, 6 years ago? People were not speaking about drones. And we got it in our face because it was one of our friends was there. It was the Ministry of what? Of Army or what? Of Defense, who took 9 months to give the approval of flying bloody drones in Madagascar when nobody was doing that. We were too advanced. Anyway, so many things, a lot, you know, the portable X-ray, the gene expert, sequencing, and a lot of other things are being tried there and in your context. So don't be shy in applying, and please apply. I am very grateful, and I know that the colleagues will speak here, but I'm really grateful of the partnership that TB Reach is growing, not only with Canada. I know Alex, where is Alex is there, with USAID, because USAID, you know, realized that it's a good beneficial thing. Yeah, so I see Alex. Obviously, we had some funding from Gates as well, and with the colleagues from WHO, because I see you guys there, because, you know, we do that with the hope that if things work, WHO then can recommend, and we can add to the evidence that they need. They need the evidence. They cannot go and say suddenly, everybody put a hat and you will be cured of TB. They cannot. They need to see the evidence that after I speak with this hat, everybody is cured of TB. So they need to have the data and to be able to verify. So it's a great partnership as well with our colleagues from the Global Fund. I see Daisy as well here in taking some of these things forward. So round 11, please apply. We want to make a case. You see, everybody speaks a lot about integration and about a lot of other butterflies. Realities are in front of you, and you know much better than what anyone else, including myself, will say about that. This new round will focus a lot on integration, but also bringing the services closer to people. When you have a vulnerability or several, accessing anything from care, diagnosis, treatment, prevention, anything is difficult. It's very difficult. Any vulnerability. I was saying just before, and it's honest, and you all, some of you that know me very well know that it's true. Coming from Romania, living in Switzerland for many years, till almost recently, when I was meeting a policeman, I was sure that if he will stop, he will find something wrong with me. I had this thing in my head because we were operating for so long with the visa. And in my country, when a policeman stops you, or used to, because I don't know now, Stefan, there is always something wrong with you. You don't have a stamp, you don't have this, you don't have that in order, you cross the street that. So, and I didn't have any vulnerability. It was just my stupid head. And then I was like, imagine how it is to be a migrant or not having your papers, an illegal migrant or a sex worker or being another color or another religion. Imagine the effort you have to do to access the service. And it can be in your country. You are very poor. You know, you don't have enough to reach the place to get diagnosed or to get your treatment. So you delay till you maybe have another occasion to go to that place. So anyway, every single barrier between a human being and the service is what is in our ending TB in front of us. So what we try with this round is to do two things. Can we bring the services closer with primary health care, with community health workers, to ensure that there is as close as possible. So it's like you get out and somebody's at your door saying, you want an X-ray, baby? If I make a mistake, the Rwanda rapper that is our celebrity, he suggested that he does a concert. And then we come with the X-ray and gene expert at the entrance. So everybody who goes at the concert get a screening. Is any of you friends with Taylor Swift, please? That will be something big. But, but we can start slow. So anyway, this kind of stuff. So, and that's one piece. The other piece is a lot about integration. As I was saying, we speak a lot about integration, and I think we spoke a lot about TB HIV. But it's time to look at integrating, like my point is, and this is, I was late because I was this week at the Global Fund board meeting and then retreat. And there is this continuous torsion and tension between doing what people call very vertical TB, HIV, and malaria, or doing health system. So I ruffled some feathers there, and my own ones, because what we do in TB and in HIV and malaria as well, it is health systems. It's not that we are doing things on parachuting things on Mars. We here on Earth do laboratories, right? We have labs that are doing TB and are multiplexing for other diseases as well. There are data systems that we strengthen, and so on and so on and so on, community and stuff. So, but my point is, we spoke about this integration. So much can be done if we do it properly. You find somebody in your hands, whatever way you have someone there. Don't do just TB. You can do other lung diseases as well with the X-ray and so on. So we are looking for integration, but because we beat so much the road of TB, HIV, and I think TB and diabetes, can we be innovative and have TB and other things? Be innovative in your own communities. Everybody knows much better how it's there, right? Things that will help in addressing other diseases once we are dealing with people with TB. So I don't know exactly the indications that will come in the proposal, but I'm very excited about this round because it can open the wings of so many things that can be done across. I remember our friend Amir Khan from IRD. He did this great thing with those schoolgirls, right? I think there were, 10,000 schoolgirls. I don't think there is any other project in the world where you have 10,000 schoolgirls that were going in their own little community around their house to find people with TB, right? How awesome is that? In Pakistan, please, not in Romania or Switzerland. So, in Romania and Switzerland, this is not happening. So this kind of stuff. I mean, this was one of the ways of bringing services closer to people. The challenge will be, obviously, we will, and this is my last point, we will obviously discuss with Global Fund to take it forward and so on. And we are much, much better as a TB community in bringing political leadership and political commitment. So there are more and more countries in which ministers of health either understand, either we push them to understand, heads of states and governments. So it might not be that we operate anymore in vacuum in terms of what we do for TB. It will be linked and ideally sustained. If it works, it might not work, You might have the 10,000 girls. It worked, by the way, in Pakistan. But I'm just saying, you might have 10,000 girls in Switzerland. It will not lead. But they might find, oh, by the way, I'm sorry, Stefan is my Romanian friend. He's a TB survivor and an amazing colleague. And I turned to him because there are some, I don't want to use example from other countries that I'm not like, oh my God, she chose my country. So I speak about Romania. But I think when in Romania, we have these X-ray machines into some vans and they go from county to county. And there is a lot of activation before for people to know. And I think that in some parts, they found more cancer than tuberculosis because people smoke in Romania or maybe whatever. Very good. Very good. Whatever. We save a life. So with this, I will stop here. I just want to leave one thing. I'm very honored to speak in front of you because every single one of you does an amazing work in the real life. And I want every single one of you to stand in front of any people like me and others if they come and tell you what you do. Because you know what you do much better than the others. You don't need that much TA. You need the resources to be able to spread your wings and fly. And that's what we will try to do as much as possible. So I'm very honored to see you here. I'm very honored to know you. and to really applaud you. And we will do a clap for all of you at the end, because as you heard, 2022 was proven to be the best year in terms of diagnosing and treating people with TB since ever. You should be very proud. You need to come and take this, because I continue like an idiot. I come closer, but I don't give up the microphone. I just wanted to say, because these 7.5 million people that were diagnosed and treated in 2022, the highest ever, we have where to grow, but it was the highest ever that we had, is not a modeling outcome, is not I have nothing against modeling and estimates. Actually, we need them. But I'm saying this is concrete, okay? And this was done in a situation, as I said, that was not convenient for us. And according to some friends and people in country, 2023 will be probably even better than 2022. So that means we are unleashed, and we should take nothing less than just going forward. And we don't take no for an answer, being it the government, being it the donors, being it Global Fund. So thank you very much, and you are awesome. Thank you.
Good afternoon, colleagues. Like all of you, Canada places a great importance on ending tuberculosis, and we recognize Stop TB for their leadership in the global efforts to help us do this. Through its TB Reach initiative, we have a unique opportunity to support innovative projects to improve the detection and treatment of TB, particularly in the most vulnerable populations. As one of the long-standing partners in the global fight against TB, Canada is proud to be a long-term supporter of TB Reach. The Wave 11 call has a really important theme: innovative approaches to integrate TB service delivery with other diseases at the primary and community level. We know that community engagement is essential to preventing and treating tuberculosis. We also know this can't be done in isolation from other infectious diseases. Wave 11 will also have a focus on gender-responsive interventions for people with or affected by TB. This will help address the unique gender dimensions of the TB response. As we know, women and girls are affected by TB in different ways due to age-related social and health inequalities, stigma and discrimination, and exposure to the infection as caregivers. It is in this context Canada is providing 25.5 million Canadian dollars to support initiatives under TB Reach's Wave 11. This will bring Canada's total support for TB Reach since 2010 to over $240 million. We are proud that our support to TB Reach has contributed to the detection and treatment of more than 2.6 million TB cases and helped to prevent 13 million new infections worldwide. The road to ending TB is a challenging one, but our collective efforts are making a difference. I wish you a successful event and Wave 11 process. Thank you.
Alexander Glubkov is from USAID. USAID has been a really strong supporter, as Luchika mentioned, for TB Reach. They've funded TB Reach projects for the last 5 waves. They've given additional funding to many of those projects after the initial TB Reach project had finished. And they're supporting a lot of TB Reach grantees to continue that work through several other initiatives, multilateral initiatives, bilateral initiatives as well. So Alex, can you please come up and...
All right, thanks so much, Jacob. So good evening, everyone. Thanks for the opportunity to provide few remarks from USAID side. So as we know, just a few days ago, WHO published a global TB report for 2023, but actually, of course, reflects 2022 data. As Luchika already mentioned, we already know that we have really a great success in the 2022 in terms of numbers of patients diagnosed, 7.5 million. Unfortunately, WHO also increased the estimation for TB, right? And now we have also a still big gap of 3.1 million people we need to find and treat. For MDR TB situation is improving, but very slow. As you know, you can see the number here. I think you all know the numbers. Less than 50% of patients with MDR TB enrolled on and detect it and enroll on appropriate treatment. So we have a lot of gaps in front of us, and I think it's what we're all doing together, you guys doing in the countries is very, very important. And thanks also to Stop TB and for TB Reach to doing this work. On the USAID side, just a few slides as part of the remarks. USAID, as you know, is the largest bilateral donor for TB. We have been working with Stop TB Partnership and TB Reach for many years. USAID been supporting, as Jacob mentioned, waves 5 through 10. USAID kind of co-funded those rounds. Those rounds, if you remember, been focusing on the case finding of people with TB, looking at bringing new diagnostics, new tools to practice. We have one round specifically focused on private sector engagement. We have one on MDR-TB. So it's really a lot that TB Reach is doing, very innovative, and we are very happy that we work together with Jacob, his team, with Luchika, with TB Reach initiatives, because yes. Thank you. Yeah, we're really proud to work with them. We have so much innovations happening through TB Reach activities. So in all of those activities really helps patients to get care on time and really improve access to care. And a lot of, as you see on the slide, a lot of pilots, really new innovations coming through TB Reach activities. So again, so we're very happy to work with TB Reach. Just a few slides, maybe. I don't know if you know that couple of weeks ago at a UN high-level meeting, USAID announced Global TB Accelerator Plus. We have had our Deputy Assistant Administrator Atul Gawande presenting this in New York. So USAID is what we announced, and have just 2 slides kind of elaborate on that. First of all, continuous support to countries. Right now, we have 24 priority countries where we work. In addition, that what was announced that we will provide additional funding to countries in the conflict settings. We're going to have also focus on localization. I will talk about that in the next slide. And also, of course, the price reduction for diagnostics and for some medications were also announced, which is also great and going to help more patients to be enrolled and detected as well. Or just to kind of combine this with our strategy with USAID strategy launched about 2 months ago, kind of combined a few key bullet points. First of all, just if you're not aware, USAID globally at large has a very ambitious target of providing at least 25% of funding to local partners. So not to international organizations as we used to know, but really to you guys, to organizations, NGOs based in the country. And that's target for overall USAID at large, 25 by 25. In addition to what was announced in New York, is that for TB funding, we have a target of 60% of our TB funding will go to local partners by 2027. So it's much ahead of overall USAID target. And as of now, about 40% of funding already going to local partners. Of course, we will continue bringing innovations and new ideas and new tools to sites, to fields. We have additional emphasis on primary health care and health workforce. For TB, for sensitive TB, it's already kind of fully integrated with PHC. But for MDR-TB, I think we have a way to go. We need to actually have more sites. And I always kind of advocate for bringing MDR-TB kind of and fully integrate with regular TB treatment. And we have drugs and opportunities for now for that. Of course, we have very ambitious targets on TB case finding, MDR-TB, and TPT. I will show the next slide quickly. And of course, patients are always at the center of what USAID is doing. This is our results framework. Again, this is part of the strategy launched about 2 months ago. It's a strategy for period 2023-2030. You see very ambitious impact level targets for incidence and mortality reductions. We have very ambitious targets on 90% of detection and enrollment for both sensitive and MDR-TB patients, and also 90% cure rate for both conditions. And of course, very ambitious target on TPT, 30 million people we would like to enroll by 2030. This is in addition to the PEPFAR activity. This is people in addition to PEPFAR because we have a separate target for PEPFAR. And also you can see what the outcomes and process level indicators and targets are. And lastly, this is just a picture of our strategy. Again, it was published a couple of months ago, and our priorities and our objectives that we have, as you can see. And so thanks so much for opportunity to speak. Congratulations to Stop TB and TB Reach for launching Wave 11. Looking forward really to seeing your ideas coming into practice. We're always trying to pick up your ideas and then the interventions that were piloted in your countries, in our countries, and then we're trying to then help them to scale up them and to have a national scale ups through USAID and as well as the Global Fund Fund. Thanks so much.
Here is Mohammed Yassin from Global Fund, who I think many of you know. I don't know if he will say this, but I will say it for him if he doesn't. Mohammed actually was in Ethiopia and applied for TB Reach Wave 1 funding. And to date, it's still, I would say, in the top 3 most impressive grants out of the 350 plus grants that we've given. So he knows it from all different sides, and we're really happy to work with Mohammed and his team in Geneva.
Yeah. Thank you very much. Thank you, Jake. Good evening, everyone. So I decided not to use the slides. And I also believe that you all are part of Global Fund, so I don't need to tell you a lot about Global Fund. Obviously, I will share my personal experience with the TB Reach as well. But just maybe to remind everyone that Global Fund is a major international source of funding for TB, accounting about 75% of overall international funding, and a unique partnership, public-private, civil society communities. The Global Fund strategy and policy to engage everyone. That's why, in one way or another, we all are part of the Global Fund, and we are proud to be part of all the partners who are working toward this ending TB, HIV, and malaria. And also to build a system which will be a resilient and also preparing for next pandemic. That's a strategic shift. But overall, Global Fund investment contributed to saving 59 million lives for the last 20 years. Those are the numbers which actually, of the number of people, not the numbers, these are people. And you are part of that and contributed to those savings. And we believe Global Fund just contributes to those lives saved, and that's a great achievement. After the successful replenishment, the 7th replenishment, the Global Fund raised the largest ever amount for the 3 diseases for the next 3 years, and already allocated $2.4 billion for the next year for TB. And that's a great, thank you very much, because that's very important. And thanks for most of you who advocated for Global Fund replenishment. That's how we are able to raise all that amount, given all the context and the challenge, especially the economic constraints all over. And that would help us to contribute to saving more lives and scale up for innovative interventions, reach those people at higher risk and who have limited access to reaching. And Global Fund strategy also calls for evidence-based, data-driven, and advocate for implementation of innovative approach to reach everyone with TB, drug-resistant TB, with a TB infection, and receive the best available screening, diagnostic, and treatment and care services along the cascade of care, and in line with what the countries are included in their strategic plans, but also in line with the UN high-level target ambitions. And we need to accelerate the push toward this ending TB. And we all are happy the progress we made, and countries struggled during COVID, not only for TB, for everything. TB disproportionately affected, but the recovery is really impressive, and I think the effort from everyone contributed to quick recovery. Last year, 7.5 million people with TB diagnosed and treated. That's the highest ever, and we need to maintain that momentum. And Global Fund is not just a grant, as you may know, that's additional plus $4 billion available through the COVID response mechanism, which contribute to mitigating the impact of COVID on TB, but also help to accelerate some of the TB response, including some of the cross-cutting intervention, the community engagement, the lab, the data system, infection prevention and control. This, we consider this as cross-cutting beyond TB and in line with our COVID response. And TB received more than 400 million additional from that one. I think that's great, and we all are grateful to our donors for their generosity. And that's really contributed to building a system and developing resilience and preparing for any future pandemic. As probably the next pandemic may also be, we hope it will not happen, but if happened, maybe respiratory, and then all the investment on TB, including all the gene expert molecular tests we invested for TB. Actually, those are the tests which are used for COVID. And the same will happen as we all are moving to more of multi-disease screening and diagnostic platform, and integrating TB, drug-resistant TB, TPT treatment with all the other diseases, and toward this integration and more of people-centered approach. And that's what the Global Fund is strategy advocates. And we need to work with all of you. And with the TB Reach, yes, I'm one of the grantees for window. I'm happy and congratulate you. That's 11th window. Yeah. And thanks for the TB Reach. That was a great opportunity for us to implement innovative approach, community-based TB case finding in Ethiopia, using the already existing health extension workers. These are community workers. They are already there, part of the government. What we have included is TB in the 18 package they have. TB was not part of that package. And it was a missed opportunity, but we had this TB Reach grant to implement that for one province, about 3 million people, not just for case finding, it for awareness and sensitizing the communities. And when they go house to house for the routine activities, they just ask for symptomatic patient and collect sputum sample. By then, there was no gene expert. Actually, in Ethiopia, we deployed the first 2 gene expert machines were through TB Reach grant from our grant in the health centers. Thank you for that. That enabled us doubling the TB case notification in the first year, and treatment outcome reached more than 95%. And we have also done the contact tracing, using the same cadres, and provided INH. It was not 3HP by then, IPT as INH. And so it's a comprehensive package of service using the communities. And thanks again to TB Reach. It was 1-year grant, but because we need to generate more evidence, we need to convince the national program to take over and so on. That took about 5 years. And TB Reach continued to support us, and we kept innovating. Of course, after we started the project, I moved to Global Fund. I had the opportunity to work closely with all the team, great team here. And that created growth. I'm just highlighting this as an opportunity. The same experience you have in different countries, you have seen in Nigeria and Vietnam and in other countries through the TB Reach funding. So it's great opportunity to test and to check if there's some innovative interventions out of the box, whether those would work or not. Once they work, then could be scaled up. And that's an opportunity for all of us. And just to keep an eye on innovative interventions so that this will not be there for years or forgotten. And that's why we have an MOU between Global Fund and TB Reach to ensure that those innovative interventions and response are incorporated in Global Fund funding requests, supported to scale up. And that's what the MOU we have. And we have seen that already contributing a lot to improve the quality of the programming in the countries, the National Strategic Plan, and the Global Fund funding request, including proactive case finding, community engagement, private sector engagement, a recent one on DRTB where most countries struggling, and all those innovations which TB Reach projects contributing have huge impact on informing a decision at country level and also informing the funding request for Global Fund. We look forward to continue working closely together, and the Global Fund resource would be a great opportunity because we always find some savings. We don't need to wait for the next cycle. Most countries have gone through the funding request for the next 3 years, but any innovations, evidence-based, and new tools could be incorporated in Global Fund anytime. Reprogramming is now part of the overall Global Fund model. I just want to encourage you, one, to engage if you are applying for the TB Reach grant, good to engage the national TB programs and stakeholders early. Whenever results are there, be proactive, and there are opportunities to make sure that those innovative interventions are supported. I probably stop there. Thank you very much again for the opportunity, and congratulations for the new win. Thank you.
Move now to hear from WHO, and very happy to have Tawhid Islam to come and say a few words about primary care, about practical approaches to lung health, and again, what we try to do, what we hope to work with TB Reach partners on is to help inform WHO and provide evidence so that they have so that they can make more recommendations and guidelines.
Thanks, Jake. Thanks, Jake, for inviting. It's always a pleasure, and especially listening to Luchika is always very, very refreshing. Thank you, Luchika. So when Jake said that there will be the TB Reach launching, I thought that this is a wonderful opportunity to share the same thoughts, and especially, more specifically, the theme of this year TB Reach is the integration. So I would like to, I mean, the integration, I think this is probably a very common theme in public health. And let's go back to the primary health care concept. So I would like to remind ourselves that why TB and primary health care need to be thought very closely to really move towards our goal. So we will very quickly look about why, what are the synergies, what are the opportunities, and some of the examples, and how do we use those opportunities. So all of us here from the TB community, and we all know that the NTB strategy guides our overall direction for the universal access towards the universal health coverage. And we all know this NTB strategy, right? But what I would like to remind ourselves, that's one of the principles, and that principle is talking about the human rights and ethics-based TB service. And to have that human rights and ethics-based TB service, we need to think about the design of the TB service, how the TB services are being provided. In the NTB strategy, the baseline preparedness is really the health system capacity. And you also know very well this graph. I think all the last 10 years we are seeing this graph, no? But this graph has an assumption. The assumption is that if we have current tools, if we don't have the new tools, then there is only one way to improve. And that's pursuing universal health coverage with social protection. We are surely need the new tools. We are excited about the new tools, but let's do our best with the existing tool. And to do the best with the existing tool is actually designing the system which will make that assumed 10% decrease which actually had in European setting earlier. So as we said that the universal health coverage pursuing is the way to really move faster or really go towards that direction. Now we should look at, rather than, we obviously look at the number of how many people we reached, all of those, but we also need to see about that universal health care service coverage index. And all of the high burden countries, you see that the index is between 40 to 60. It's a long way to go. So there must be something what need to be done to move that up, to go towards that direction. So universal health coverage is actually a goal, is actually a dream. But how do we reach that goal? How do we reach that dream? The last year, World Health Assembly came together and all the member states agreed and calls for reorientation of the health system based on the primary health care, which will take us to the universal health coverage. So the primary health care is the vehicle, is the way to go to the universal health coverage. Obviously, I will not repeat it, all the colleagues mentioned, but the recent UNHLM, we acknowledge that the way towards going the universal health coverage, ending TB, we need to go through the primary health care approach. Now, when we say that the primary health care approach, what do we really mean? We probably, many of us mean probably many different things, but the primary health care approach is actually a whole of society approach to health that aims to maximize the level and equitable distribution of health and well-being. In some cases, primary health care, we think about the level. Obviously, the first level or the primary level is the major component of primary health care, but the referral is also part of it. Primary health care means that the promotive, preventive, curative, palliative treatment service for along the life course will be provided. And it needs to have the integrated service delivery, multi-sectoral action, and community empowerment. So when Jake mentioned that integration, I thought that's the best synergy here. We are talking about the same primary healthcare approach. And that's the way to go towards the universal health coverage. Now, just to make the connection that the primary healthcare, what we are talking here is the approach, the health system is the means, and the universal health coverage is the goal or dream. Now, as we always focus on our TB economic case, you can also look at the primary healthcare economic case. In primary healthcare economic case in Kenya setting, it has been proven that in $1 invest in primary healthcare, for the diseases like tuberculosis, the return is $16. So obviously, the current evidence is it's towards that primary healthcare approach really helps. In the Brazilian setting, it actually proved that the community-based primary healthcare could strongly reduce TB morbidity and mortality. In current WHO guidance, which are all that evidence-based, at least in the 4 recommendation directly talks of the component of the primary health care, such as the family-centered integrated service, integrating with the other disease program, community-based, and involving all the sectors. So let's come that where we meet together. This is the recent primary healthcare framework, and that has the 3 components. Let's look at the NTB strategy, and it actually matches exactly the NTB strategy. One pillar is that integrated service delivery, and the bold policies are exactly same as that multi-sectoral and the community empowerment. And all the levers the primary healthcare colleagues preach, that all are related with TB. So there are great synergies, and we have to take those opportunities. Now, coming to the point, because this topic is more about the integration. So what is the integration, or what is the integrated health service? So integrated health service, if we only say one sentence, that it doesn't talk about the disease, it talks about the people. That it only addresses the people's need. And if anything address people need, that will be the integrated service delivery. One of the example is that hub of the service and network model, which is the primary healthcare, where all other services can be delivered through the same hub. Or what Jake was mentioning, that one of the example could be integrated approach to lung health, which probably many of you knew previously as the practical approach to lung health. So, TB is not a single island in the public health arena. So there are many other public health areas, and probably we need to really look at that, what are they doing and how are they aligning themselves with the primary health care. You can see that the HIV, non-communicable disease, health emergencies, and the vaccination all are quickly jumping and riding on that primary health care vehicle towards the universal health coverage. So, just to align with this launching of TB Reach 11 call, the 3 points. One is the health system design has a major potential to improve TB outcome. And I hope that this TB Reach will really try to make that system design innovation. Secondly, that the system design with the current modality, the primary health care model is currently known the best model. So finally, what TB program should do, maybe they really need to find out the synergies, the different context, the different countries, it will be really different, but probably need to find out that how far are we from that primary healthcare approach, and let's bridge that gap. So just what I said, that the 3 things, if we see it visually, that we always talk about, or we need to talk about the TB specific activities, that's for sure. But we need to talk that through the overall health system, which is integrated, where community is empowered, and where multi-sectoral action is there. And even then, we need the beyond health. So currently in many countries, the system probably or may look like this, or may look like a little bit different. But what we need to do, we need to design a system which actually meets the criteria of 2030. I believe that our aim should be designing that system rather than the number of the cases. But TB community, as a TB community, how do we do that? We probably don't have that much power. So maybe the TB community with that TB Reach type of project influence the design and advocate and partnership with Beyond Health. With that, I thank you very much, and thank you for inviting.
So I'd like to invite Dr. Stephen John to come. Stephen works in Nigeria and has been a recipient of several grants over the years, and is going to talk about work in Wave 10, providing services to nomadic and IDP communities.
Thank you very much, Jake. And let me start by thanking the Stop TB Partnership for giving me this opportunity to take us through this journey of our experiences in ISD as we deliver services to key and vulnerable populations. So, I think the most commonest words heard so far in this conference could be key and vulnerable populations. And everybody knows that, especially us here, that these are special populations that live in remote settings. And of course, they have lots of issues around health facility. You know, the number of health facilities, access is a serious problem. Human resources are not there. And then you also have problems around even the equipments like the microscopes and all the things that are required to carry out the basic test. They are either obsolete or, you know, forgotten completely. And at the end of the day, you know, it's about quality being very, very poor. So that is a huge problem. So this makes it challenging for low and middle income countries, government to deliver services in these areas. So therefore, partners like us will have to do our best to bridge this particular gap. So, of course, we know that KVPs, as the key and vulnerable populations, they also suffer from combination of afflictions. It's not only tuberculosis, there are various diseases. They could be pulmonary, but of course, there are others that are not pulmonary. So they are left out, and this has to continue among this very important group. So the unmet need keeps building up because of the disadvantages that they face. So these unmet needs provide an opportunity for alternative care providers to jump in. And who are these alternative care providers? We're talking about patent medicine vendors, we're talking about community pharmacies, we're talking about traditional healers, and even spiritualists who claim that they can pray and heal people in these particular settings. So such services leave the KBP's communities with increased transmission of diseases, including tuberculosis, and then high rates of morbidity and mortality. So at the end of the day, where do they end up? They end up in a situation where they are more marginalized, they are more socially excluded, economically as well, and then they are there at a high risk of TB with continuous transmission, and of course, a high proportion of missing people with TB. So the objective is just to take you through this journey of what we do in ISD, and then of course to see, to look at the experiences from an ISD project that we are running in Nigeria. So you can see pictures of community engagement, which is a very, very important component of making sure that you successfully deliver ISD during outreaches. So integrated health service delivery through outreaches. So TB service delivery for many, many years have remained verticalized. So this we know, and it is a missed opportunity that, you know, because there are other health challenges that are actually left behind. So this leaves the key and vulnerable population to seek care, you know, for other conditions separately, which draws down on their out-of-pocket expenditure and other difficulties that they face. So this underscores the need to deliver TB services in an integrated manner. So integrated service delivery provides also opportunity to tackle multiple diseases at the same time, like we have heard. And of course, commonly, some of the diseases that we try to look at the same time will be TB, asthma, NTDs, for example, leprosy, which has always been together with a TB in an integrated manner, the nutrition, diabetes, and other non-communicable diseases. So it's not that you deliver the service completely. For example, you go and be looking for diabetes door to door. But if you're in a facility and there's a unit that takes care of diabetics, you know, just providing TB services to such unit also provides access and is a form of integration. So unfortunately, due to lack of interest, challenges with funds, governments are not able to address these issues as they should. So the burden keeps growing among key and vulnerable populations. Community-based outreaches provide a special opportunity to reach these KVPs. And with support from Stop TB Partnership, for example, the TB Reach Wave 10, which also has a component of ISD through our foundation, we're able to develop over the years, not just the Wave 10, but from Wave 2 that we've started, we're able to build our capacity and then improve on our community engagement, which has given us this particular path to make sure that we engage the community properly and deliver ISD. And outreaches became part of all the interventions which targeted key and vulnerable populations. So our projects target nomadic people, internally displaced persons, refugees, and of course, minors lately. So, of course, we have support from a challenge facility also in some of the projects, like the one that looks at refugees. So in all this, the strategies that we engage these communities are the same, and we try to go the ISD way. And it's good to know that other organizations like WHO, USAID, you know, they also support outreaches in our communities in Nigeria for especially. So this provides opportunity to address TB, leprosy, HIV, and of course, provide referral services for what we cannot attend to. For example, we use portable X-ray to screen people. So nothing stops us from referring the people we find that we think have had problems. We have seen people that are almost in failure, and one of the signs will be cough, and health workers could easily think that this is tuberculosis. So, but the image will show that the heart is enlarged already. So nothing stops us from referring these people to the right point that they should get the care that they need. So these are some results from just a few local government areas for 2 quarters, 6 months. So you can see a combination of nomadic people, IDPs, minors, and people living with HIV. So in total, in just 6 months combined, we were able to screen over 33,000 people, and then we found over 4,000 presumptives, tested 3,009, and then ended up with 471 TB cases, people with TB. So you can see again in the pictures, these are our teams delivering outreach services. You can see how nomadic people are queuing up to have an X-ray. So in a community where silicosis is the problem, nothing stops you from suspecting and linking people with silicosis care if you think that is the problem. So any disease that is prevalent, of course, like Luchika said, why not? Check it out. So again, this is the leprosy component. This is from just one state. We're able to screen over 5,000 people and test over 130, and we found 15 cases of leprosy, and 13 of them were enrolled on treatment. Now, this is only in 4 local government areas, but the entire state, in 16 local government areas, they found 34 in the same period. So you can see, because of looking out and then doing it proactively, active case finding, looking out for leprosy as well, this is what we found. And these are some of the pictures from the field. That's a child of about 13 years old. If you find a child with leprosy, it means that transmission is continuing. And then the 2 pictures are people that were detected with already disability grade 2, so we call it. If you find people with disability grade 2, it means you are detecting them late. So these are the people that constitute the burden of leprosy in the community. And unfortunately, funding for leprosy has dropped completely. So integrated service delivery is the way. So in conclusion, I would like to say that ISD models present a great opportunity to us, to improve health service delivery. It addresses packages of health issues at once, like we have heard, and it improves access to health services for key and vulnerable populations. Promotes functional integration. That means a healthcare worker will do multiple disease entities, address multiple disease conditions at the same time without referring to the next person. It also reduces the impact of stigma. For example, for leprosy, we know that even people with TB stigmatize against leprosy cases. Those that don't have grade 2 disability stigmatize against their brothers with grade 2 disability. So all this kind of thing, if you do integrated services, you have a chance of reducing this stigma. And it improves the quality of health service delivery as well. It lowers projects' operational costs. You don't have to go twice. You go once, you can do a lot. But if you don't do it in an integrated way, you have to go multiple times. And there are other benefits. So as we work towards ending TB, we could do more for key and vulnerable populations. Thank you very much.
Rabia put together and managed the largest outreach in the world of screening, mobile van screening. They did 1.4 million something, I don't know, a lot, well over 1 million chest x-rays all over Pakistan. But she will be presenting now the work on TB Reach, again, Wave 10, on integration with hepatitis and TB.
Thank you so much, Jacob. Thank you. That's what I use. Hi, everyone. Good evening. It's really nice to be here. And thank you so much for inviting us to speak and talk about our Wave 10 project, something that's very close to our hearts. So I'm Rabia, as Jacob mentioned. I'll be talking about our Wave 10 program, which is integrated TB, hepatitis C, mental health, and COVID-19 screening and service delivery in rural Sindh. Some of you may know about our work from the NTB clinical trials, where we used a strategy to engage with communities called the community action groups. These are basically groups that use and incorporate, not the word use, sorry, include community members, people with lived experiences with TB, caregivers, and others, to provide perspectives and input and feedback into designing protocols, for implementing research and just implementing disease-centered care in these settings. So what our learnings from this showed us that this would be the best way to design a program for any area for which these services need to be, where these services need to be delivered. And so in doing that, when we were designing this project, we wanted to use the same approach and expand on it. Our understandings of rural settings in Pakistan was that people live more as communities and function as networks to support each other. And we thought that this was the best place to build a program that was led by the communities. We started by gathering insights from locals in these areas. And here we have an example of one such story that we heard from a man called Anand Kumar, who was a is a medical dispenser in one of the districts we're implementing in, and he's also a part-time farmer. And he was sharing this experience of how people from his community fall sick during cotton picking season, and they don't really know what's causing it. And because they don't have access to immediate care, what he does is that he stocks medicine in advance, just so that he's able to support the people that live nearby and are able to deal with emergencies. So this is how these people function. They work through these synergies and help each other. We decided to then use the insights that we gathered from these communities and from these individuals to design the goals of our integrated service delivery approach. And these are some of the goals that we thought that we would like to focus on. The provision of integrated services, obviously for a more person-centered approach to care, focusing on diseases that were more prevalent in these areas. Designing a community-based approach to care that would improve access through point-of-care testing. We would screen in the communities, we would provide point-of-care testing and diagnostics and decentralized models of care delivery. We wanted to take everything to the people. Developing local capacity. This is a big one on our project. Enhancing capacity, health promotion, building trust and awareness and inclusivity. This really helps sort of penetrate into these communities and help help themselves. And optimizing for scale up. We're trying to use a task shifting approach where we want to optimize the use of scarce resources like we all have. And so that there's more feasibility to scale up such programs. So these have been some of the goals of our approach. When deciding the population that we would like to have implemented this in, we had several considerations. And something that was key was that we wanted to work in rural areas. Our selected districts were 3 districts in rural Sindh called Tandwala Yar, Mirpur Khas, and Tharparkar. We selected these districts because these are high TB burden areas. They have very low case detection rates, as low as maybe 30 to 40%. And so a lot of people go undetected. They're low resourced, of course, and they house a lot of marginalized and minority populations that are actually scattered through these areas. And so we thought that these would be some of the places that we would like to go into. This is just a brief overview of our community-led model of care delivery, which starts with identification and mobilization. We took on board locals from these communities, and we upskilled them to become community mobilizers. Now, these community mobilizers started working through their own networks in these communities to enroll community members into community action groups. And it is through these people that we mobilize people within these districts to come to these decentralized camps. The decentralized camps that are community-based use mobile X-ray vans to provide integrated screening, testing, which is point of care for TB, hepatitis C, COVID-19, and a mental health assessment for common mental disorders. Any people that are identified with having any of these conditions are then linked to care through a range of models of care delivery based on preference, which could be in-person care at a health facility, decentralized care within the community through a mobile clinic, or through telehealth services. Our project started implementing in July of this year, and just in 2.5 months, we've been able to conduct over 50 camps. We've already screened over 7,800 people. We've found over 70 TB patients, over 150 hepatitis C patients, and over 50 people with common mental disorders, all of whom have been linked to treatment and support. Thank you. As part of the health system strengthening approach, we've been building these community action groups. And when we built this presentation, we had already enrolled about 45 members into these community action groups. These people have been upskilled and have started conducting awareness sessions and advocacy sessions in their own communities and have already conducted over 10 of these. And they have made about over 350 referrals to these camps. Additionally, our mobilizers have referred over 700 people to these camps. So all of the movement is happening from within these communities. We've also started working with local public and private sector healthcare providers. Again, an effort to improve the system and strengthen it, right, to allow this integrated service delivery approach to be taken up and scaled up further. And so this is basically a gist of our program. I'd like to acknowledge the work of the teams, the IRD CEC collective that has worked very hard and has shared their experiences and has been working with us to implement this. The ISD ground TB program, which is actually implementing this in very difficult settings. And of course, our partners, the CDC Sindh and TB Reach, the Stop TB Partnership, for providing us this opportunity. Thank you.
Thank you. So I'm just going to run through the theme, timelines, eligibility, the documents that we have, which you can see, and what we're looking for. It's been said repeatedly. I won't spend too much time. It's around integration. It's around integration with focus on lung health. And we would like proposals to do 4 things. We want to see proposals that do improve detection and care for people who have TB, promote people-centered integrated service delivery for TB and lung health closest to the point of need. Canada mentioned, and it's important, and it's not it won't be as developed in the first stage of the application, but it will be something that will be a theme throughout, is proposals that are gender responsive and incorporate aspects of thinking about how we provide better services in a gender responsive way. And again, to Mohammed's point, looking at ways to sustain not necessarily the organization and that their funding, but the interventions, and that it can form national scale-up, if successful. This is generally the different areas that we see TB Reach projects that that we want to see them address. Not all of them, but some of these aspects. There are cross-cutting approaches, and I'm not going to read them out. There are service delivery outputs, and there are health outcomes. These should improve the health system strengthening, and we will be asking applicants to describe how they think that their approaches will contribute to health system strengthening. It's been said many times that we, over the years, from the early parts of active case finding, and again, what Mohammed didn't say is that he got a lot of flack and pushback on this intervention from a lot of people and organizations. But now everyone takes active case finding and community outreach, and it's normal, right? And that wasn't the case when we started this in Wave 1. But we have a long history of pushing our partners to provide care closer to people and communities that need it. And as Tauhid mentioned, primary healthcare focuses on people's needs, both as individuals and communities. We want to get in and provide these services, and we want you to show us how you're going to do that as early as possible and as close as feasible, maybe not outside the door, as Luchika said, but as close to feasible to people's everyday environment. I think it's important to mention that we are okay with accepting a proposal on TB and malnutrition. We are okay with it, having proposals that look at TB and mental health, but there must be an aspect of lung health as well. So there has to be TB and some other lung disease condition that is being addressed, and you can add on to that other non-communicable diseases or diseases outside of lung health. I think I'll be repeating, but from myself and others, what they've said in terms of what the reasons why we want ISD proposals, but as I said, we want to see lung health, and we do not want to be funding, as Luchika said, TB and HIV proposals, TB and diabetes. This should be part of national TB responses already. So it's not something that we think TB Reach should be funded. Okay. We do not want to tell you what to do. We think your ideas are probably going to be much more broad than ours. But I do just want to throw a few ideas on here. Do not take this as in any way as an endorsement. But as Stephen presented, active case finding, first point of contact. Bringing new diagnostic tests for TB, diagnostic tests for other diseases closer to the point of need. Evaluation of those of diagnostic tests, maybe that are not WHO approved. Multiplexing testing platforms. So that's one of the best ways we can talk about integration, and seen a lot of it with COVID. So multiplexing testing platforms, we're happy to see proposals that engage the private sector. We're very happy to see digital health proposals. Someone mentioned lung cancer earlier. Artificial intelligence, again, has been widely mentioned during this week. And beyond TB, there's a lot more than that can be done. And importantly, I think it's also good to mention that it's not just the biomedical approaches. Social protection, we're happy to look at proposals that are working on social protection schemes. Eligibility, who can apply, and are you eligible to apply? So you can look at the website. This is the eligibility criteria. You can look at the website for the list of actual countries. There's I think 97 countries that are eligible to apply. It's much more than in some of the previous rounds. So we really we're hoping that this will source a lot of ideas from many different places. But in general, low income, high TB incidence, or really high TB, HIV, MDR, TB, according to WHO's guidelines. We also will accept multi-country proposals. So you're free to apply for multi-country proposals, and you are free to apply for more than one proposal. You can apply. You can send in 2 or 3 proposals for Pakistan. That's totally fine. You won't get them funded, all of them, but you can apply. Now, organizational eligibility. We will fund any nonprofit, not-for-profit entity in the country that is non-governmental. So we cannot fund with the new funding national TB programs or state programs or provincial programs, but we do encourage them to be subrecipients. We encourage the primary applicant to be subrecipients on the proposals. And as Mohammed said, it really helps with potential sustainability and links to Global Fund. So we will accept proposals from universities. We'll accept proposals from international NGOs, local NGOs, but we do have a priority of funding, and I think the last round, about 75% of the proposals were from locally registered NGOs. So we will give priority to locally registered organizations. It's not in the slide, and probably a lot of people are interested to know. The cap for funding will be $550,000. So and it's the same timeline. It's for 18 months of work that we've had in the past. And there will be a deduction of $35,000 for the M&E work that is standard for TB Reach grants and has always been there, or has been there for the last 7 or 8 rounds. So the effective budget that you will have is about $515,000, and there are several caveats to that, but that's what we're looking at in terms of the amount of money. Now to go through the timeline, and just so you understand what we're looking at and when you should be thinking that this may take place. So today we're announcing the call. The website is live. In many countries there will be holidays in December and early January. We decided not to push you too hard to write it. So the application website will close on the 17th of January. And our independent proposal review committee, 17th of January. So usually TB Reach, we give you about 6 weeks. So now we're giving you almost 9. So, so you have more time. So the first stage will be due on the 17th of January. And our independent proposal review we expect a very large number. We have a large number of countries. We expect a large number of proposals. And those proposals will be reviewed by our independent proposal review committee. And in early March, we expect to send decisions out to all applicants. And a proportion of them will be invited to submit a stage 2 proposal, and the others will end that process there. Then they will have another period of time to develop a stage 2 proposal, which is a little more in-depth and writing and more data heavy. And we expect we'll then review the proposal review committee will sit together in May and make funding recommendations to the executive committee of the board in June. And the board will approve, we hope, we expect, and grant signing will happen over the summer, or summer in Geneva, and we expect to have a grantee workshop in end of Q3, beginning of Q4 of next year. So that's the general timeline. In the past, we've had acceptance rates of 3, 4, 5, 6%. It is a large call. Please don't blame us if it's very competitive about funding. But that is the process. All applications must be submitted in our online portal. We do not accept any emailed proposals. Please read all of the supporting documents. There's much more information in there than we have provided tonight and have time for tonight. But there's a concept note, technical brief, questions and answers, budget information that I don't have enough time to get into, but there are lots of rules around what we can fund in terms of overheads, in terms of human resource requirements and things like this. And think about the data that you are presenting, why you are presenting the proposal. I think one of the things that we get, the feedback that our PRC, our Proposal Review Committee, gives us every year is explain why you are proposing this and back it up. Why do you need to have service delivery, integrated service delivery with leprosy? What is the burden? What bottlenecks are you addressing? And so there's a lot of data that is requested if you are selected, and that will start even in the application process. We want to get proposals and grants across the globe from every region. We try to fund proposals in each of the in the Americas, in Eastern Europe. We always have lots and lots and lots of proposals from Africa and Asia. It's not a problem. But we really want to see a wide variety of proposals looking at different disease areas, looking at different populations. So it's not necessarily a thing to do what everyone else is applying. It can actually be beneficial not to. and it changes. You can talk to people who have been on our review committee. The discussions, it's impossible to know what we want and or what they want and what will they like. But address the need, as Tao had said, address the need that is presented in the communities where you're going to work. If you have questions, and I think we're not going to take questions because I think you're all exhausted, and we'll have time afterwards and you can approach us. Our team is here at the table, and you can talk to them now, but you can always email us with questions, and we will respond to the questions and we will put them up on the website. We'll update the frequently asked questions document. It's on the website. All of the documentation, all the concepts, notes, everything is in all of the UN languages. We will also accept applications in all of the UN languages, and we will translate those for the review committee. And that's it, and good luck. Luchika would like to say one more thing.
Sometimes we think that, when you say, I have this, that's easy. And then we had amazing applicants that didn't get funded, I think because they said, oh, it's simple. And as I said, it's not us. There is a review committee that works a lot to develop the proposal. Some of you might be here in the room and so on. So please, sometimes you are shocked. And it's the same with Challenge Facility for Civil Society. Amazing people applying, but then rushing and so on. So that's what my plea is. Put yourself in the shoes of the reviewer. I'm not saying any Einstein stuff here. It's simple. And see, do people understand what we want? Does it make sense? Stuff like that. And don't think that, okay, I had already 2 rounds. I know these people. I mean, I know TB Reach. I know how it works. It will be easy. It might be, but it's just that we are sure. We hear, oh, they applied. I'm like, yay. And then we had some group that I think had some great lab hope into a tool, and they were planning to work in some countries in Africa. There was a group from Jerusalem, they were highly scientists. They were amazing, and it didn't go through. Right? It broke my heart. But I mean, you just hear, and it's like there is no way that you can. That you can understand why they did this. But anyway, just this was a word of caution and so on.
Thank you so much. There's refreshments outside, some drinks, some canapes. Thank you very much for coming again. And we'll see you tomorrow.